Let's look at anesthetic options during labor. Probably the most common one used around the world in the United States is narcotics. Narcotics are easy to give intravenously, intramuscularly. They are inexpensive. Limitation is you can only use them in the first stage of labor, not in the second stage. When in labor are narcotics given, we already talked about this, you would like to avoid them in the latent phase because you can get into prolonged latent phase. So typically we'd start them in stage 1 active phase. We typically don't want to give them after a prime is completely dilated or a multip is 8 centimeters dilated. And the reason is that if there is high levels of narcotics and the baby's born, we can have neonatal depression. And the baby needs to take its first breath and expand its lungs, and if it's sedated, can't do that. What if you give the narcotic and all of a sudden baby's out 10 minutes later? Baby's depressed. Naloxone. Naloxone to reverse the narcotic depression in the newborn. Paracervical block. Paracervical block is where we will inject into Frankenhausen's ganglion on either side of the cervix 2 to 3 cc's of local anesthetic. Very effective if it works. However, you get very high concentrations of local anesthetics which can go to the fetus, which can result in transitory fetal bradycardia. This is what it looks like. The heart rate is looking good, you give the block, and all of a sudden you get this bradycardia, and the heartbeat is now boom, boom, boom. And your anal sphincter tightens and your heart rate goes up. What are you going to do? Crash cesarean? No. The management of transitory bradycardia is just wait. And over the next few minutes, as that narcotic is diluted and is spread throughout the body, what will happen to the heart rate? Comes right back up. So don't panic because of the transitory bradycardia. Pudendal block. Pudendal block is an injection of the pudendal nerve as it comes around the sacrospinous ligament. Now this is all done by proprioception. You're feeling for the ischial spine, you can't see it, and you have to make sure when you put the needle in, you withdraw first, make sure you're not in the pudendal artery. And you will then put on the right side 2 to 3 cc's, and on the left side you'll put 2 to 3 cc's. It can be very effective, and it can give you good pudendal nerve relief. And this is going to be in the second stage of labor. The paracervical block is for the first stage, this is for the second stage of labor. The epidural block is sometimes known as the Lexus, the Cadillac, the BMW of OB anesthesia. What's nice about this is it can be started in stage 1, it can go all the way through to stage 2. You notice we go through the ligament here. Here is the dura mater. We do not go through the dura, we go epidural. We can pass a catheter through, pull out, this is a 2E needle they call it, a 14-gauge needle, and we can leave the catheter in, we can give continuous infusion. And here we have the catheter, and we're infusing in the anesthetic. And you can continue on even if you have to do a cesarean, and you get adequate relief for that as well. Now, we could, however, go too deep with our needle, and here is our needle. This is a ligamentum flavum that we go through. The dura is the red circle here, and we don't want to go through that. We want to get into the epidural space. We gradually go with our needle a little bit deeper, and once you get through the ligament, you have a loss of resistance if you try to inject air, and you know you're in the epidural space. What if you go too deep, like this? A wet tap, we call this. Cerebrospinal fluid comes out, and the patient gets a spinal headache. Super duper headache. When she's laying flat, it's not so bad, but as soon as she sits up, pounding headache. So what do you do for this? Lots of hydration, oral IV hydration. Does that help? No. Then we give intravenous caffeine, xanthine, I don't know how it works, but often that will help. If that doesn't do it, then you will do a blood patch, and you put another epidural needle in to the epidural space. You take 5 to 10 cc's of the mother's own blood, inject it in through the needle, and as it coagulates, it'll seal that rent, that opening which you made in the dura, and within minutes, the headache is gone. It's really quite miraculous the way it works, real quick. The most concerning side effect of epidural and spinal, this is called regional anesthesia, is a hypotension from sympathetic nervous system blockade. You see, our vascular constriction is maintained by the nervous system as well as by the hormones. When you block the sympathetic nervous system, there is suddenly this increase in capacitance and the blood pressure drops. And typically, if you have a spinal for a cesarean, the patient will first say, I feel like I'm going to throw up. When she has a sense of nausea, you can be almost sure that she's got hypotension. Now, how do you manage this? Well, the first thing, make sure you have adequate prehydration. Give her a liter or 2 of IV fluids to begin with, so you have adequate fluid in the intravascular space. The other thing would be to put her in the left lateral position, take the weight off of the uterus, off of the inferior vena cava, and then give ephedrine. Ephedrine is a vasoconstrictor and hopefully will bring back up the blood pressure. All right, as we finish this section, this is an amazing story of a man who faints after seeing an epidural anesthesia being given to his wife. He was asked to support her as the anesthesiologist was putting in the needle, and he fainted, fell, hit his head, subdural hematoma, and died. Can you believe this? The moral of the story is, don't have Papa helping out. Give him a break, let him be just a Papa. All right, and that's the end of anesthetic options during labor.